Hello, welcome. I'm Dr. Thomas Meek, and I'm going to talk today about medication-assisted treatment and understanding the pharmacologic approach to opioid use disorder. The goals of this talk are to understand what is MAT and how it applies specifically to opioid use disorder. And in order to do that, we need to really get a good understanding of what is addiction. What is addiction really, and how does it apply in some other common illnesses? How does MAT compare to the treatment of some other common medical problems? When do we taper or discontinue therapy, and why does it matter? So what is MAT? In order to discuss what MAT is, I think first we have to discuss what is opioid use disorder and understand opioids. So in order to do that, I have chosen a video excerpt from the 2-Minute Neuroscience series.
The term opioid refers to substances that bind to opioid receptors, usually to exert pain-relieving effects. Opioids can be found naturally in the opium poppy, or they can be partially or completely synthetic. In addition to pain relief, opioids also cause sedation, anxiety reduction, and euphoria, along with a variety of other effects. When opioids bind to opioid receptors, they promote potassium conductance, which makes a neuron less likely to fire an action potential. And they inhibit calcium conductance, which makes a neuron less likely to release neurotransmitters. What effect these actions have depends on where the receptors are found. When opioid receptors on neurons in the spinal cord that carry information about pain are activated, it can inhibit the transmission of pain information to the brain. Opioids can also act on descending pain modulatory systems to reduce pain. For example, by binding to receptors in an area of the brainstem called the periaqueductal gray, opioids can prompt the inhibition of pain signaling in the spinal cord via a pathway that first synapses in the medulla. Opioids can reduce the emotional impact of pain by acting in brain regions like the anterior cingulate cortex, and they increase dopamine levels in areas like the nucleus accumbens, which may contribute to the reinforcing qualities of the drugs.
So this last part of the video I think is really important in understanding addiction. So it has to do not so much with blunting the pain response as it does to turning on reward centers in the brain, areas of the brain that it feels good, feels pleasurable, and that has to do with feeding into addiction. So to understand that a little bit more deeply, let's take a look at a separate video. This is from Psych Hub.
Why are opioids so addictive? For starters, they do an amazing job of reducing pain when you first take them. And they give you a rush or a high that many say they want to experience again. In addition, once people start using opioids for more than a short time, they start to need more of the drug to get the same effect. This is called tolerance. Then, as the drug leaves the body, people experience bone and muscle pain, exhaustion, and often feel really sick. This is withdrawal. The quickest way to feel better during withdrawal is to use the drug again. These things in combination make it incredibly hard to stop taking opioids. Sometimes people need help.
So what is the opposite of pain? It's pleasure. And that's sort of the basis of the process of addiction as it pertains to opioid use. So this is a visual analog scale from left to right. It goes from bad to good. It goes from unbearable pain to no pain. This is a pediatric edition. This is a tool that we use in medicine all the time to try to help gauge a patient's pain complaint and also their response to treatment. So it's also a good visual to understand the process of addiction. So the individual who is suffering potentially from physical and psychological withdrawal symptoms is on the left side of the spectrum. And as they seek out, obtain, and administer more drug, they try to tend towards the right side of the scale. As this process goes on, as tolerance goes on, they're repetitively less and less able to achieve the happy smiley face to the right. So why is this such a big deal? Why is opioid use disorder such a big deal? Because it's among a big contributing factor to the leading causes of death, one of the leading causes of death in this country. So in 2020, last year, heart disease, cancer, and COVID, right after that, number 4 on the scale from top to bottom, unintentional injury. And if we look at this a little bit more closely, the types of unintentional injury, the most common are car wrecks, falls, and overdose. I think it's safe to say that before overdose there is use, and with use there's a greater association of motor vehicle accidents and unintentional falls. So big contributing factor to the number 4 cause of death in the United States. So this is where MAT comes in, medication-assisted treatment. What is it? So medication-assisted treatment is part of a comprehensive program. So it's medication to be used as a tool or as an adjunct, and it's not intended as a standalone or a magic bullet. And it works much better when it's implemented as part of a comprehensive plan. Using medication solely without part of a comprehensive plan usually doesn't turn out as well as desired. So this is a graphic that at the top shows the brain and shows an empty opioid receptor, the site where the medication would bind in the brain and the nervous system. And then on the bottom from left to right, there are 3 columns. And it represents 3 ways in which different medications can act on these receptors. So on the left, there's methadone, which is considered a full agonist and generates an effect. In other words, it occupies the receptor and it generates an effect that is similar to the drug of choice or to the opioid. So methadone has been used for a long time as a very good pain medication, but it has been until recently the standard of care for medication-assisted treatment until buprenorphine, Subutex, Suboxone became available. So on the far right, we have an opioid receptor which is blocked. So it's blocked by an antagonist. So naltrexone is a medication that completely seals off the receptor or inhibits and disables an opioid medication to bind to that receptor. So there can be no effect if a person takes an opioid for, if they're trying to seek a euphoric high. And then in the middle, there is a opioid receptor that is occupied by buprenorphine. So buprenorphine is a partial agonist. So it binds to the receptor like methadone. It occupies the space, but it does so in a way that it only exhibits a limited effect. So there is a threshold or a ceiling dose of the medication, usually about 24 to 28 milligrams. And if individuals take more medication than that, there's typically no response. So I kind of think of this in terms of an analogy of the opioid receptor as being a parking spot. The methadone is a car or a truck that just occupies that spot. It takes up the parking space. Naltrexone blocks off the spot. You can't park in that space. I think of it as police tape marking off the space. And then buprenorphine is like the big orange cones that they use on road construction. So if you fill up the parking space with the orange cones, you can't park there. But it definitely occupies the space. If you add more and more cones to the parking space, it's not really gonna make a change in the effect. It's not gonna block off more parking spaces. It's gonna just have a sealing effect on that particular space. So if we look at this again graphically, methadone comes in oral forms in both pills and liquid as well as injectables. Methadone can only be used at specifically credentialed and designated centers. It can be used by physicians for pain management, but not for opioid use disorders outside of a designated methadone clinic. So I'm really going to focus on the middle 2 columns, buprenorphine and naltrexone. On the right, the naltrexone comes in both oral medications as well as long-acting monthly injectables. And these are used both for opioid use disorders as well as alcohol use disorders. It's important to understand the difference between naloxone and naltrexone. So naloxone, which is the ingredient in Suboxone, has been around for years, used by emergency room doctors and paramedics, and it reverses the effects of heroin and other opioids involved in overdose. So essentially, in this case, naloxone, it acts very similar and in the same way as naltrexone, but it bumps off meds like Percocet, hydrocodone, oxycodone, fentanyl, Opana, those sorts of things. So naltrexone acts in the same way as we saw on our graphic, but really the difference is the delivery system. So naltrexone is absorbed orally, and naloxone is not. So naloxone can be delivered via nasal, a nasal delivery system. It can be injected, or it can be put in an endotracheal tube if somebody is unconscious. So wait a minute, if Suboxone has naloxone in it, how does that work? The idea is that the naloxone in Suboxone is part of the preparation to discourage IV drug use. So if an individual had used opioids previously and then were to inject Suboxone, the naloxone then would potentially induce withdrawal or reverse the effect of drugs that were on board. So that can be confusing. The brand names of these medications, so buprenorphine as a standalone oral agent is Subutex, as a long-acting, month-long injection, it's Sublocade. And then Suboxone, as we discussed earlier, it's buprenorphine and naloxone. So what's cool about that is it acts in two different ways. So you have the buprenorphine medication, which is a synthetic opioid partial agonist. So it is used for pain management in some cases, but as a replacement therapy and to prevent use and abuse of other opioid drugs. And then also the naloxone is part of the preparation, again, to discourage IV use. So together, these medications are packaged and they come in strips or pills or tablets. Who can provide MAT? So licensed medical professionals, DOs, MDs, nurse practitioners or physician assistants. And based upon experience, specific credentialing and training, these medical providers can prescribe up to a limited number without any additional training, just on-the-job training and learning about the medication through residency and other medical training programs. Individuals can start off and prescribe up to 30 patients. But then there are patient limits for up to 100 and 275 respectively, and that again is based on experience and specific credentials, typically being board certified in addiction medicine and or psychiatry. So in recognition of the epidemic of opioid use and abuse and overdoses, the current administration has sought to make prescribing of buprenorphine more readily available. So this goes to the being able to prescribe the medication without additional training up to 30 patients. How can you become waiver trained, as it's termed? So you have to have a DEA number to prescribe controlled medications, and then you need to seek out what is called waiver training, and this reflects back to the Drug Addiction Treatment Act of 2000 in recognition of the need for these medications to be used by various providers in the medical community. So the Substance Abuse and Mental Health Services Administration is a site where individuals can log on and seek training. Also, the Providers Clinical Support System is a site that can offer various training modules. And a lot of this stuff has been web-based for years and now is more so obviously due to COVID from last year. So hopefully that is helpful in understanding the various medications and how they work. But now let's talk about what is addiction. What is addiction really? So here's the Merriam-Webster definition. that it's a compulsive, chronic, physiological or psychological need for a habit-forming substance, behavior, or activity having harmful physical, psychological, or social effects, typically causing well-defined symptoms such as anxiety, irritability, tremors, or nausea upon withdrawal, or the state of being addicted. Now, that's kind of long and convoluted. Number 2, strong inclination to do, use, or indulge in something repeatedly. A cleaner version, a more simplistic version with a medical tilt from Medical News Today. What is addiction? It's the inability to stop using a substance or engaging in a behavior even though it's causing problems. It's causing psychological and physical harm. So if you just look at the word and drill down on the word itself, when you keep adding and adding and adding a substance or repeating a behavior, even though you know you shouldn't, even though it's causing things to get icky, even though it's causing a situation or patients who continue to use or participate in behaviors develop a condition associated with that where they find themselves being sick, but they're not able to stop adding to the sickness. That's addiction. That is, by definition, addiction. Let me jump out here and go to another video that I think, at least for me, kind of crystallizes a few things.
And alcohol.
So this fellow is Eric Clapton. Many know him, his music, pretty famous dude. Has also been very outspoken and open about his challenges with substance use disorder. So this is what he has to say about it. This is taken from an interview with Ed Bradley from 60 Minutes a ways back.
I couldn't get through a day without doing something to alter my consciousness.
And it started with heroin, the addiction.
It started with sugar, man.
Sugar.
Oh yeah, when I was 5, 6 years old, I was cramming sugar down my throat as fast as I could get it down. Sweets, sugar on bread and butter. I became addicted to sugar because it changed the way I felt.
And as the years passed, Clapton would do more and more to change the way he felt.
So here we have one of the most famous and in some ways revered musicians or artists of our time describing his addictions. But, from his perspective, where it started was with food. As a child, because, the food, specific food, sweets, treats, food that's maybe not so nutritionally sound, and how it made him feel. And so that lends itself to another super common problem in the United States and another epidemic, obesity. So common, serious, costly disease. How common is it? These are numbers from 2017-18, but almost 42%, that's almost half the population characterized as being overweight or obese. It's a big deal. How big of a deal is it? It is a significant contributing factor to the top 10 causes of death in the United States. So number 8 on the hit list from top to bottom, diabetes. Diabetes, super common. Most people are familiar with it. 90%, nearly 90% of individuals with type 2 diabetes are overweight or had obesity at the time of their diagnosis. So if we go from top to bottom looking at these top 10 causes of death, heart disease, we find that all of them are linked with obesity, various cancers. COVID, you have a much greater chance of having a severe case or a poor outcome if you do become infected. We looked at unintentional injuries previously, stroke, COPD, dementia, influenza or pneumonia, and chronic kidney disease. So another big issue with obesity is chronic pain. And so individuals who are overweight have more wear and tear on their joints and are much more likely to develop earlier onset arthritis, strain on low back, hips, knees, ankles. So this is pretty common. Relative to normal weight people, overweight people reported 20% greater rates of recurring pain, and the higher the class of obesity or the heavier the individuals were, the greater chance that they would have issues with pain. So we have this issue, we have the situation where we have these two epidemics. We have obesity, where nearly half the country is overweight or obese, and then we have these very alarming numbers and significant contributors to the number 4 cause of death related to illicit substance use. So obesity, direct relation to chronic pain, direct relation to pain meds, direct relation to opioid use disorder. So I think of this together as this double ought, this double negative, like a double barrel shotgun. There are these two epidemics that are ongoing in our country right now, obesity and opioid use disorder. And the thing to me that makes it interesting is they are both conditions that are stigmatized. There are social stigmas applied to both of them. I think in either case, I don't think any individual in the world wakes up and says, oh, I think I would like to be opioid addicted. It doesn't work that way. Nor do I think anyone wakes up and says, yeah, I would like to be obese. So it's a group of individuals that have these struggles and face these stigmas, and in some ways the treatments are the same. And so I want to look at that. In terms of the treatment success and the rates of remission, the numbers are startlingly similar. So in community settings, remission of type 2 diabetes does occur without bariatric surgery or weight loss surgery, but it is very, very rare. Again, I picked these numbers from diabetes with the reminder that almost 90% of type 2 diabetics struggle with obesity. So in the third line down here, I don't have a pointer, but the third line down, prolonged remission was 1.47%, so between 1 and 2%. What's interesting about that is when we look at those numbers compared to 1 and 5 year remission rates with treatment for drug and alcohol dependence, the numbers are almost exactly the same, between 1.2 and 2.2%. So how are these treatment approaches using MAT similar or different? So the use of MAT for opioid use disorder compared to the medication treatments for obesity. So again, we have our graphic with the brain and the opioid receptor. One of the things that makes methadone and buprenorphine successful is that when they bind to these receptors, they evoke this pleasure response. So if you kill pain, or if you blunt or diminish pain, then that equates to a pleasurable or favorable experience. Let's look at the addiction of tobacco. So a lot of people have used a product called Zyban to help stop smoking. It is bupropion, which is also known as Wellbutrin. The molecule bupropion has been around for a long, long time as an antidepressant. The way it works in the brain is it doesn't necessarily bind to opioid receptors, it does not, but it does affect the way the brain manages, handles, distributes certain neurotransmitters, dopamine and norepinephrine. And this goes back to the pleasurable effect. Quitting smoking is a very hard thing, so if you add a chemical to it that to some degree enhances the amount of dopamine or norepinephrine that you have and makes you feel better and happier, that you have some reward from the medication, it helps stop smoking in that way. So interestingly, bupropion, exactly the same medication, and naltrexone, the medication that we looked at earlier that does bind to opioid receptors, is used in methamphetamine use disorder. And so this came out in the New England Journal of Medicine in January of this year. So this is exciting, but these are this study provided very, very modest results. And in other words, this is not, again, a magic bullet, but it is a medication that was shown to be somewhat helpful in helping folks discontinue or diminish the use of methamphetamines. So this is Contrave. The magic, the secret ingredients of Contrave are naltrexone and, look again, bupropion. So the same exact medication that is used to treat methamphetamine use disorder is used to treat obesity. and help with weight loss. So that's pretty interesting that it's the exact same chemical to address two completely separate issues. So when do we stop? When do we taper therapy? And that's not a straightforward question. The short answer is it depends. The questions that I always ask when dealing with individuals struggling with these issues is the treatment working? If it is working, why would we stop therapy? If it's improving an individual's quality of life, if it's helping them achieve their goals, or if it's diminishing the amount of harm that they're causing themselves, why would we stop a therapy that does that? If it is not working, why would we continue? So if an individual was losing weight, I wouldn't stop their contrave. But if they were continually gaining weight, why would I continue it? Similarly, if an individual were consistently showing appropriate urine drug screens and demonstrating an improved quality of life with less drug use, why would I stop medication-assisted therapy? So I would look at them very similarly. So another tilt that is if you think of a very common scenario, this might be a scenario of many people that you may know. Mrs. Jones, a fictional character, is a pleasant lady with a history. She had a heart attack a year ago. She had a history of breast cancer, and she's overweight. She's obese and diabetic. But she still likes to eat donuts. She still likes to bake. That's important to her. Are you going to stop her treatment? Are you going to stop her blood pressure medicines or cancer treatment or her insulin because she relapses and eats donuts? We don't typically think of eating, poorly nutritious foods as a relapse, but individuals with this condition, it's contributing to their overall issue in most cases. So the answer is no, we're not going to stop treatment. Are you going to set a timeline? Are you going to determine a duration of treatment? And the answer again is no. So very commonly in the treatment of these common illnesses, obesity, diabetes, heart disease, individuals are committed to a lifetime of therapy. So it's a chronic condition or a chronic disease that deserves chronic, in most cases, lifelong maintenance. And so the same is true with addiction disorders. Individuals, the pathophysiology is different, but in many ways the process is the same in the brain and how the brain perceives pleasure and how it seeks craving of various things, whether it's donuts or drugs. So, there's a lot of stigma related, even in the medical community, about, oh, well, you're just getting somebody off of one thing and onto another. And the answer is yes, that's accurate, that's true. But getting someone onto something else, a medication-assisted treatment, a medication that will improve their quality of life and reduce harm. And so if it doesn't do that, then it's time to talk about discontinuing the medicine. So the bottom line is if the benefits outweigh the risks, then therapy should be continued. And if that's indefinitely, so be it. So this is a quote that's attributed to Jim Carrey. Whether Jim Carrey said this or not, I don't know, but it's on the internet, so he gets credit. He said, "I believe depression is legitimate, but I also believe that if you don't exercise, eat nutritious food, get sunlight, get enough sleep, consume positive material, and surround yourself with support, then you aren't giving yourself a fighting chance." So, he's focused on depression here, and he's talking about, really pursuing a comprehensive, healthy lifestyle. If you do that, you have a good shot at improving and elevating your mood. But I think you could fill in the blank here with any of those top 10 things that we looked at, with obesity and with opioid use disorder. And so, to clarify, I think it's important, again, to revisit that, I'm trying to draw parallels between obesity and opioid use disorder. They're both epidemics in the United States. They both have their chronic issues. They're things that happen over prolonged periods of time. And they both require chronic treatment. The incidence of remission is very similar with treatment, and the medications that we use to treat them is very similar also. They're both conditions that are socially stigmatized. So a lot of similarities and then some very obvious differences. But hopefully that helps in some way just to understand medication-assisted treatment. So MAT is a tool. It's part of a comprehensive program, and it makes me think of the parable of the hungry man. And if you gave him a fish, then he could eat for a day. But if you taught him how to fish, he could eat for a lifetime and feed his family. So if we just give individuals medications, whether it's for obesity or whether it's for opioid use disorder, or whatever the case may be, management of chronic disease with pills is not awesome. Our track record as physicians in curing or arresting and reversing these conditions is very modest. And so whatever the case may be, medication has to be used in the context of a comprehensive treatment program otherwise to be as successful as it can be. So hopefully this has been helpful. I will make my contact information available, and if there are questions, comments, or otherwise, please reach out to me. And thank you for the time.